Hello everyone. Today I have a lecture on pediatric seizures to prepare you for our didactics on Friday. The learning objectives I will be covering today are review the pathophysiology of seizures and identify the most common types of seizures in children. First, I'm going to quickly go over the International League Against Epilepsy classification of seizure types, which changed in 2017. The first main branch point is based on where the seizure originates. Focal seizures originate in networks which are limited to one hemisphere of the brain, whereas generalized onset seizures spread quickly to both hemispheres. Focal seizures can be further subdivided in those with preserved awareness and impaired awareness, and those with motor onset and non-motor onset. Of note, focal seizures that progress to bilateral tonic-clonic seizures were previously known as secondary generalized seizures. In this updated classification, they're now called simply focal to bilateral tonic-clonic seizures, but you may still come across the old nomenclature. Generalized onset seizures are also divided into motor and non-motor seizures. An example of non-motor seizures are absence seizures, which will be covered later in this lecture. And the final category is seizures with unknown onset, and these too can be motor or non-motor. Infantile spasms fall into this category and will also be covered later. Next, I'll touch briefly on the pathophysiology of seizures. The pathophysiology of seizures is still under active investigation and is not completely known. But today I will touch on a few pieces of evidence that suggest what some of the pathophysiology might be. First, I'm going to touch on pathology. The most well-studied pathological correlate of seizures is known as mesial temporal sclerosis. This is the most consistent finding in surgical specimens resected from the temporal lobe of patients with complex partial seizures that were refractory to treatment. This pathology is characterized by loss of pyramidal cell layer neurons, but relative preservation of the dentate granule layer. The origin of this pathology is unclear. It's not ischemia because ischemic damage has a different characteristic appearance. And in fact, it may be a consequence of seizures rather than a cause of them. And in animal models, this pathologic appearance can actually be induced by inducing seizures in those animal models. Seizures do seem to have a relationship with cellular communication, and a lot of this has been demonstrated through pharmacology. GABA, the main inhibitory molecule of the brain, seems particularly important. GABA A receptor blockade can produce epileptic activity in experimental models. And in human patients, GABA agonists are frequently effective at terminating seizures and often are the final line for difficult to terminate seizures, and these include benzos and barbiturates. Interestingly, in premature brains, GABA activation can paradoxically cause excitation and depolarization in addition to inhibition. And some have hypothesized that this might contribute to increased seizure risk in infants. Glutamate is the main excitatory neurotransmitter, and sort of in the inverse of GABA, glutamate agonists have proconvulsant activity, and some glutamate receptor antagonists have anti-epileptic properties. A final note is that glia may have a role in seizures. Many of the functions of glia include regulating extracellular ion concentrations and neurotransmitter concentrations, and it is not a far leap to think that this could impact the excitability of the brain. Finally, genetics are important in the pathophysiology of seizures. Epilepsy does aggregate in families. Evidence at this point shows that most syndromes are probably polygenic, but some single gene mutations have been implicated. These include T-type calcium channel mutations in the reticular nucleus, and these are involved in burst firing, as you can see in the graphic on the right. Other single gene mutations include nicotinic acetylcholine receptors, sodium channels, and GABA A channels, and each of these is associated with an epilepsy syndrome. A pattern I noticed here is that most of these are an ion channel. Next, I'm going to touch on the epidemiology of pediatric seizures. This is a graph which shows aggregate data from several studies looking at the epidemiology of pediatric seizures in developed countries. As you can see, the incidence of seizures broadly appears to be highest in infancy and gradually tapers throughout adolescence. The biggest pattern in which children get seizures is that more children in developing countries have seizure disorders than children in developed countries. It's about a 20 to 50% higher rate. And this most likely has to do with increased risk of CNS infections and toxic exposures. Most studies don't show any difference in gender, and studies haven't shown differences in race, although generally the populations of these studies have been too difficult to directly compare. Finally, I'm going to discuss some common types of pediatric seizures. Excuse me, I'm going to take a sip of water. The first type is febrile seizures, which is something that many of us will most likely see in our career. It's seen in about 2 to 5% of all children in the US before the age of 5. The peak incidence is between 5 months and 3 years. And it's defined as a seizure that in association with a febrile illness with a temperature above 38.4 at some point in the illness. It can actually be after the seizure and still qualify. In the absence of a CNS infection or acute electrolyte imbalance. Some risk factors for febrile seizures include a family history of febrile seizures, a NICU stay greater than 30 days, developmental delay, and participation in daycare. About 90% of febrile seizures are tonic-clonic type seizures, but luckily the prognosis is excellent. Most children will grow out of this syndrome, and the risk of epilepsy is only slightly increased compared to the general population. So if you see a child like this in the emergency room, your primary role will be to reassure. Next, I'm going to discuss Lennox-Gastaut syndrome. About 2 to 5 per 10,000 births result in a child with this syndrome, although the onset is typically after infancy. It's defined as a syndrome with 3 criteria. The first is multiple types of intractable seizures, cognitive and behavioral impairments, and the last is a typical abnormal EEG pattern. There are several seizure types which are characteristically associated with this syndrome. The first is tonic seizures in sleep, which are defined as sudden increases in muscle tone, and they don't necessarily occur in sleep. The second is atypical absence, which is similar to atypical absence seizure. However, it has a more unclear onset and end. And the final type is atonic seizures, which are also known as drop attacks. These are characterized by a sudden loss in muscle tone and often lead to falls and may prompt children with this syndrome to consider interventions such as wearing helmets all the time to prevent injuries secondary to these falls. About 70% of cases of Lennox-Gastaut have an underlying cause which can be identified. These causes might include structural brain abnormalities, history of CNS infections, trauma, or genetic causes such as tuberous sclerosis. The prognosis of this syndrome is limited. Most of these seizures are somewhat refractory to medication. The seizure type may change in adulthood, but generally some type of seizures persist throughout adulthood, and cognitive and behavioral impairments persist through adulthood as well. These are some patients who may benefit from a ketogenic diet, as their seizures are often refractory to medication, and ketogenic diet has been shown to help in some patients. And this is an image of the characteristic EEG pattern that's seen in Lennox-Gastaut syndrome. Next, I'm going to discuss childhood absence epilepsy. The incidence is 7 in 100,000 children, which makes it about 8% of all childhood onset epilepsy. Childhood absence epilepsy is defined as multiple daily absence seizures in a child between the age of 4 and 10. And often these children are having tens or dozens of seizures in a day. There's a similar syndrome known as juvenile absence epilepsy, which usually presents in children between 8 and 20 years old. In this syndrome, the seizures may be less frequent, and the syndrome is more commonly associated with non-absence type seizures. Childhood absence epilepsy does seem to have a genetic cause, as shown in twin studies, but specific genes have not yet been identified. It doesn't have many known risk factors, but it is occasionally associated with a history of previous febrile seizures. The prognosis of the syndrome is good. Most cases resolve in adulthood, and it's extremely responsive to ethosuximide therapy. And here you see a typical EEG pattern that would happen during a childhood absence seizure. It has a 3 Hz spike and wave pattern. Juvenile myoclonic epilepsy is a syndrome that occurs in between 6 and 100,000 people under the age of 25. Quick caveat, most of these studies have been done in Scandinavian populations, so it may not reflect the broader population accurately. It's defined as myoclonic and generalized tonic-clonic seizures in an otherwise normal adolescent or young adult. These seizures typically begin between the age of 8 and 25, and on EEG, you see a generalized spike and wave and polyspike and wave pattern. The prognosis is fairly good, as 80 to 90% of these patients are pharmacoresponsive. And here you can see a polyspike and wave pattern that is slightly blurry. I apologize. Benign Rolandic epilepsy, also known as benign epilepsy with centrotemporal spikes, is a syndrome that appears to be very common in certain parts of the world. In a study in Iceland and a study in Italy, about 25% of the overall cases of epilepsy in children were benign Rolandic epilepsy. However, a study done in Minnesota showed a number closer to 5%. The onset is typically between age 3 and 12, and it has a very characteristic seizure type. And often the seizures involve twitching and stiffness of the face without loss of awareness. Seizures can also involve numbness or tingling of the face. And the reason for this is that the seizures begin in the Rolandic area of the brain, which is on the fissure in between the motor and sensory cortexes that control the face and oropharynx. Interestingly, these patients often present with a tonic-clonic seizure. Because their typical seizures with motor disturbances of the face are not super obtrusive, it'll often take a progression to a tonic-clonic seizure for them to present to medical care. This syndrome can also be associated with headaches, migraines, and behavioral and learning differences. The cause is unknown, but the prognosis is very good. Most children outgrow their symptoms by puberty, hence the name benign. The final syndrome I'm going to discuss today is infantile spasms, and this is an important one to pay attention to because it's important to intervene early and intervene aggressively. It's fairly rare, About 2,500 children in the US are diagnosed with this syndrome each year, and it's typically seen in children under 1 year of age. The presentation is often quite subtle, and it might include head drops, or a mom might describe that it looks like her baby is trying to do crunches. The longer that these spasms continue untreated, the higher the risk of poor developmental outcomes, which can include developmental delay and autism. However, quickly treated children can do quite well. They're diagnosed by their very abnormal EEG pattern and should then be quickly started on treatment. And this is another syndrome in which an underlying disorder can often be uncovered, and this might be a pyridoxine-dependent seizure, tuberous sclerosis, or any number of other causes. And that is the last syndrome I'm going to cover today. These are my references, and I encourage you now to take a few minutes to watch Fred's presentation, which will discuss the treatment of childhood seizures.